Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Adjuvant Chemotherapy for Non-Small Cell Lung Cancer in the Elderly, a population-based study in Ontario, Canada by Shinad Koufe et al. My name is Corey Langer, and I'm the Director of Thoracic Oncology at the Abramson Cancer Center and a Professor of Medicine at the University of Pennsylvania in Philadelphia. My oncologic specialty focuses on thoracic malignancy. The title: The Use of Adjuvant Therapy in Elderly Patients with Resected Non-Small Cell Lung Cancer, or NSCLC. Adjuvant therapy based on the ALT, JBR10, and ANITA trials has become standard of care post-resection in non-small cell lung cancer patients with documented nodal involvement, both stage 2 and 3A. Its role is a bit more controversial in T2N0 patients whose tumors measure more than 4 centimeters in size. The LACE meta-analysis documented a 5% absolute improvement in 5-year survival for cisplatin-based regimens in the adjuvant setting, though individual studies have demonstrated a greater relative benefit, particularly in node-positive patients. Non-small cell lung cancer, however, is predominantly a disease of the elderly, who have been underrepresented in all of these trials. The ALT and ANITA trials explicitly excluded patients over the age of 75. While retrospective subgroup analyses of JBR10 and the LACE meta-analysis have suggested that the elderly could benefit from adjuvant treatment, the numbers were relatively sparse, raising questions regarding the reproducibility of these data in clinical practice. Using the Ontario Cancer Registry, which centralizes virtually all provincial data regarding malignancy, the authors identified non-small cell lung cancer patients undergoing definitive surgical resection from 2001 through 2006. Registry data were linked to electronic treatment records, which included information on age, gender, stage, and chemotherapy regimen if instituted. The uptake of chemotherapy was compared across 4 distinct age groups: those under 70, those between the ages of 70 and 74, those between ages 75 and 79, and those 80 years of age and older. As a proxy of survival benefit from chemotherapy, the authors compared survival of surgical patients diagnosed between 2004 and 2006 to those diagnosed between 2001 and 2003. Hospitalization rates within 6 to 24 weeks of surgery served as a proxy of severe chemotherapy-related toxicity. Among 6,304 surgical patients, 2,763, or 43.8%, were elderly, by definition 70 years of age or older. The use of adjuvant chemotherapy in the elderly increased significantly from 3.3% between 2001 and 2003 to 16.2% between 2004 and 2006, when the results of the positive adjuvant trials first began to emerge. Among evaluable cases, 70% of the elderly received cisplatin, while 28% received carboplatin-based regimens. The incidence of dose adjustments and drug substitutions was similar across all age groups. Hospitalization rates within 6 to 24 weeks of surgery were similar across age groups: 28% below 70 years, 27.8% at 70 years of age and older, with a p-value of 0.54. 4-year survival of elderly patients increased significantly, though modestly, from 47.1% between 2001 and 2003 to 49.9% for those diagnosed between 2004 and 2006, with a p-value of 0.01. Survival improved in all elderly subgroups, except in patients 80 years of age or older. So despite a relative paucity of randomized data in the elderly, the uptake of adjuvant chemotherapy for non-small cell lung cancer in Ontario increased in the elderly after the report of pivotal adjuvant chemotherapy trials showing a survival benefit. A modest but clear-cut and statistically significant survival benefit was observed in the elderly, even though the uptake of adjuvant chemotherapy was still under 20%. Tolerability was similar across all elderly age cohorts and did not seem to differ significantly from those under 70 years of age. This paper is important in its documentation of real-world practice and how clinical trial results may influence outcome outside the research arena. However, the results of this retrospective analysis still raise many questions. Number one, what percentage of the elderly would have been candidates for adjuvant treatment based on nodal status and tumor size using current NCCN criteria? Did comorbidities or surgical complications limit the uptake of adjuvant treatment? And did the preferred use of cisplatin in this setting in an aged population with potential contraindications to this agent further limit uptake? Number two, to what extent did patient selection or improvements in surgical technique lead to a survival increment? Number three, would the magnitude of the survival benefit have been more pronounced had the uptake of adjuvant chemotherapy been greater? Number four, was the survival benefit seen exclusively in stage 2 and 3A disease, or did it extend to stage 1B? Number five, finally, were the benefits similar for cisplatin and carboplatin-based regimens? Over time, new studies will likely address most, if not all, of these outstanding issues. In the interim, the authors, led by Drs. Couffet and Shepard, are to be congratulated for their painstaking analysis, and the province of Canada should be commended for the centralization and accessibility of its cancer database. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.